Hi everyone, welcome back to my channel. My name is Dr. Kiruka Bridget at OB Talks with Dr. Ada Zion. Thank you for subscribing to my YouTube page. Thank you for watching the videos and liking and commenting. Thank you for following me on Facebook page, also at OB Talks with Dr. Ada Zion. I'm also on TikTok and on Instagram with the same name. Today, we'll be talking and continuing our discussion on female factor infertility. We've discussed some, the cervical factor and the uterine factor. Today we'll be talking about the ovarian factor, the tubal factor, and the peritoneal factor. If you have not watched the previous videos, please do well to check those videos. Thank you. Let's go on with our discussion. I'm going to tell you a medical story. When a woman is pregnant and that baby is destined to be a girl, within the first 13 weeks of pregnancy, that's at the first trimester, that baby's ovary starts developing, the oogonia starts forming. Now, it continues to develop until 28 weeks to 30 weeks. That's about the 7th month to 8th month of pregnancy. So at that time, it has reached its maximum number. And the number is about 6 to 7 million. You can imagine that. It's quite a big number. So when it has reached up to 6 to 7 million, it remains at that stage. And what happens is that it doesn't grow more than the number, rather it starts decreasing in number. So the egg in the ovary starts decreasing in number. However, it waits at that phase until the person enters puberty. So when a baby girl is born, that 6 to 7 million eggs that developed has decreased to the extent or that it remains about 2 million at birth. Now it continues to decrease until puberty, when it's about 500,000 remaining. And this 500,000 continues to ovulate, continues to shed until menopause. It's a beautiful story. So before a girl child reach reproductive age, that's when it enters puberty, at about 12 years, the hypothalamus, that is the brain, the hypothalamus pituitary axis develops, and the hormones that help to cause ovulation comes in place. And this is why the girl child starts ovulating and has a cyclical menses. So at each month, she sees her period. Sometimes many eggs are recruited. They are recruited to ovulate. However, one is chosen to become the dominant follicle. That's the Graafian follicle. And that's the one with the effect of luteinizing hormone, what we call mid-cycle hormone. That one comes out as the ovulation. And so if the person is ready to get pregnant, a sperm fertilizes it. If not, the person goes on to see her period, enters the luteal phase, and progesterone takes effect, and later she sees her period. Now that is what happened. Ovarian factor infertility is one of the commonest causes of female factor infertility. And most times, it's about ovulation dysfunction. Some women will have anovulation. Anovulation means failure to ovulate at all. And it may be as causes of ovulatory dysfunction will affect the frequency and duration of the menstrual cycle. Now, it can occur as form of anovulation or failure to ovulate. In such women, it may be associated with primary amenorrhea or secondary amenorrhea. Primary amenorrhea means they have never seen their menses before. And secondary amenorrhea means they have seen their menses before and suddenly the menses stops. or it can even be oligomenorrhea. The cycle length is longer than 35 days. Remember, we said that the normal cycle length is between 21 and 35 days. So anyone that has about 35 days, more than 35 days cycle length, is abnormal and may be associated with anovulation. So when someone is unable to ovulate, a lot of things could be factorial to it. So anovulation is one of the commonest causes of ovarian factor infertility, and in such women, when they are found out, we can help them with drug to cause ovulation so that they can conceive and have their baby. Sometimes age is a factor that contributes to anovulation. You know, as older as a woman gets, the ovarian reserve decreases and she may present with anovulation. So this is always advisable that at before 30 years, someone should start giving birth, because for as the woman advances in age, her ovarian reserve continues to grow smaller. So for those that don't ovulate at all, their menses may not come. So anovulation is one of the causes of female factor infertility. Now, there's another condition of the ovary that is known as polycystic ovarian disease or polycystic ovarian syndrome. What happens in polycystic ovarian disease is that there is quite normal good ovary. Merely looking at the ovary is there. But however, these ovaries are tiny and filled with cysts. When looked through an ultrasound, they measure between 0.5 to 2 millimeter, and they are arranged peripherally on the ovary, on the surface of the ovary, like beads, like necklace. So it's called necklace ovary. So they're arranged as beads around the ovary and they are filled with cysts. Such women don't ovulate as well, and they can have just maybe in 1 or 2 times they sporadically ovulate. There are signs to know that a woman have, or symptoms to know that a woman has polycystic ovarian disease. However, ultrasound diagnosis, looking at the ovary, will show this necklace appearance of the ovary filled with cysts arranged peripherally, up to 10 eggs arranged peripherally on the surface of the ovary and filled with cysts. It gives the diagnosis of polycystic ovarian disease. There will be other factors associated with it, because these women with polycystic ovarian disease, they tend to have more of male hormones, what we know as hyperandrogenism. So because of the presence of male hormones in their body, they tend to grow beards. They tend to have beards on their chest, hairs on the chest, hairs on the abdomen. In fact, they have male pattern of hair distribution. These same women may be obese. Now, these same women, they may have a change in voice. Their voice may start looking like that of the men. And when an investigation for hormonal profile is done, you see that male hormone is high, and there is what we check in the follicle stimulating hormone and luteinizing hormone. This gives you a clue that that woman has polycystic ovarian disease. About 50% of women with polycystic ovarian disease do not see their menses. They have amenorrhea. About 25% comes with irregular menses, and 12% will have cyclic menses that you won't even know that they have polycystic ovarian disease. The only thing is that they will not be able to conceive. And when you investigate such women, they will see that they have polycystic ovarian disease. So women with this type of disease is advised, one, to seek medical attention. Secondly, there are some things we do. We advise them to lose weight. If you're able to, we found out that if they're able to lose about 10% of their body weight, they tend to have sporadic ovulation, and the person can go on to get pregnant. Then we can also use some things to help with the acne, from plucking to other management that will be discussed in the hospital. So these women can be managed and they can have their babies anytime they want. The only thing that is associated with conditions like what we know endometrial cancer. So such women should be monitored closely to make sure they do not have endometrial cancer or endometrial hyperplasia. So that is another part of ovarian factor infertility. So women with polycystic ovarian disease, you know this by their inability to ovulate, that is anovulation. There is presence of hirsutism, that is hyperandrogenism, and there is presence of peripherally arranged cystic eggs, that is ova. The ovaries are peripherally arranged with cysts 0.5 to 1 millimeter in diameter, more than 10 10 number. And there is also, these women are, they have normal breasts, they are well developed like normal women. However, they have unopposed estrogen. So their estrogen level is so high that they are well estrogenized. You see them, they are so shining, more shining than more normal women because of the effect of estrogen on their skin. But this unopposed estrogen level predisposes them to the risk of endometrial cancer or endometrial hyperplasia that I talked about. Now, the laboratory, when you do a laboratory investigation, you see androgenic level in their system. Then we see raised luteinizing hormone. So there's a reversal of the luteinizing hormone, follicle stimulating hormone, luteinizing hormone ratio, more than 2. So they have that. And even sometimes you may even see hyperprolactinemia in this type of women. So, but management depends on what it is seen. They're also prone to insulin resistance and they may present with glucose intolerance. These women should be adequately managed and they'll go on to have their baby. Is a type of infertility that may be easy to manage, but when it wants to prove difficult, it's actually sometimes difficult to manage. So, but they can be managed properly in the hospital and they will go on to have their baby. Now, we're now going to go into tuber factor infertility. Please, before we go on, if you have not subscribed, subscribe to my YouTube channel at Dr. Nkiruka Bridget, OBGYN Talks with Dr. Adazayon. Follow me on Facebook page at OBGYN Talks with Dr. Adazayon. Look for me on Instagram and on TikTok. I'm still with the same name, OBGYN Talks with Dr. Adazayon. So let's go on. We're talking about tuber factor infertility. Now, in tuber factor infertility, I'm going to tell you another story, a medical story. The tubes are connected to the uterus by the sides, just like I'm showing you in the diagram below, above. So, what happens in normal tubes? You know, female reproductive system works in harmony, synchronously to achieve fertility. So, but in tuber factor infertility, the ovary, what happens is that normally the ovary releases the egg, that is ovulation. And this egg released are placed in the cul-de-sac in the peritoneal fluid. The ovary and the fimbrial, just like my hands, goes below to pick them behind. And when they pick these eggs, they transport it through the tubes. This is in normal tubes. They transport it through the tubes and get them to the ampulla of the tube. There's a place called ampulla of the tube. It's the widest place in the fallopian tube. And when they get the eggs to the place, the eggs, the sperm, the capacitated sperm that has been prepared from the cervix, transported through the cervix into the uterus and to the fallopian tubes, now gets to that ampulla and fertilizes the egg. After fertilization has taken place, the process of the tube and its cilia move the egg that has been fertilized, they move it into the uterus where it gets implanted rather. Now, in tuber factor infertility, any damage to the tube, either obstruction, partial obstruction, or destruction of the cilia, can lead to infertility, abnormal implantation, or ectopic pregnancy. So, in tuber factor infertility, it's also a cause of infertility. And what are the causes of tuber factor infertility? In a woman that has had pelvic inflammatory disease, mostly from gonorrhea and chlamydia, there is destruction of the cilia. And if there is destruction of the cilia, even if the fimbriae, that is the end of the tubes that is like this, picks the egg from the cul-de-sac and sends it to the ampulla, it may not be proper. If it fertilizes, it will not be implanted, or it may be implanted in an abnormal area because it may be implanted in that tube because the cilia movement in the fallopian tube is damaged by those organisms. And pelvic inflammatory disease as well may lead to adhesions, and these adhesions may totally block the end of the tube, and so the egg cannot even be picked. Talk more of transporting it into the tubes. So pelvic inflammatory disease is the major cause of tuber damages. Now, if there is destruction of that cilia, the end is totally closed, egg will not be picked. sperm will not be transported to meet the egg. So, and even the normal secretion from the fallopian tube will not be removed. And so they tend to stay in the tube and cause what we know as hydrosalpinx. The tube will now get dilated and it becomes a problem. Even if when the person wants to do an in vitro fertilization, it may affect fertilization. So this is what happened in tuber factor infertility. Now, if there are adhesions that may not be from infection, that is pelvic inflammatory disease, other adhesions, peritoneal adhesions in affecting the tube can also lead to tuber factor infertility. What do I mean? We have discussed endometriosis. You may look for the video and watch. Endometriosis may affect the tube because it will cause adhesions with the tube to the peritoneal organs and the tube will be distorted. So movement of cilia may be affected. Picking the eggs will not be possible. Movement of the egg for fertilization may be impaired, leading to tuber factor infertility. It's actually a difficult, sometimes tuber factor infertility is one of the difficult ones to treat. However, it can be treated. In some women, it can be treated. For others that have had salpingectomy, in the tropics, most women with ectopic pregnancy present late. They present when it has ruptured, and those at that time you may not be able to salvage the tubes. So for someone that has had salpingectomy following surgery, mostly for ectopic pregnancy, it may be difficult. That is, the person is left with one tube, and if the one of the tube, the remaining tube, is damaged by pelvic inflammatory disease, it may lead to another ectopic pregnancy, or it may be blocked to pick egg, leading to infertility. Now, for women that have had two ectopic pregnancies, especially when she has had both salpingectomy, that removing of the total or part of the tubes on both sides, she may present with tuber factor infertility. So that is that for tuber factor infertility. Now the next is peritoneal factor affecting female fertility. Now peritoneal factor affecting infertility. The uterus, the cervix, the tubes and the ovaries are located in a space, and this space is the peritoneal space. So if there is anything that affects this space, which is the peritoneum, it may cause infertility. What do I mean? In people that have adhesions in that peritoneum affecting these organs, just like we've explained before, it will lead to infertility. Now, for some women that have endometriosis, especially the severe one, it may cause adhesion of one organ to the other, distorting the nature of that organ, and the person may not be able to conceive, leading to infertility. So the peritoneum is actually important because it's a space that harbors the reproductive tract. So it should be as free as every other part of that reproductive part for fertility to occur. Now we are going to talk about the last one we are going to discuss is factors affecting both couple, that is both the man and the woman. Remember, we say the men contribute, the female contributes, then both couple can contribute to infertility, and we now say that unexplained is 5%. Unexplained, we don't know what is causing, so we may not explain it, so it remains unexplained. However, for both couple, the following affects the both couple, and it may affect their fertility. So factors affecting both couples could be environmental occupational factor, then toxic effects related to tobacco, marijuana and other drugs, exercise, then extreme weight loss or extreme weight gain affecting either or both couples. So we're going to take environmental and occupational factor. When when patients that are infertile patients or patients looking for pregnancy comes, one of the questions that they are asked is, where do they work? Because it's presumed that chemical or radiations can affect production of both the egg and the sperm. Remember when I explained the male factor infertility, we expect the man not to put the scrotum where it will be affected by temperature. We don't want high temperature for the sperm, for the scrotum, because it may affect the process of spermatogenesis. So anything causing radiation, excessive heat, we do not advise those looking for children or desiring pregnancy, to allow that to affect their body, because it may lead to disruption of production of eggs or disruption of production of sperm. Now, another is toxic effect related to tobacco use, marijuana and other drugs. Smoking affects fertility of both couples, both male and female. The chemical substances present in tobacco, like nicotine, polycyclic aromatase hydrocarbon, they affect spermatogenesis in the male. It causes decreased sperm formation in the male, and it decreases the testicular size in the male, and this invariably leads to infertility in the man. Also, marijuana and its metabolite has been found to cause ovulatory dysfunction in the female. Smoking and the component of smoking affects cervical mucus of the female. This will affect sperm motility in the woman and will affect the ciliary movement of the egg. So, for someone looking for desirous of pregnancy, we advise them to avoid smoking, avoid use of other drugs like marijuana, heroin, cocaine, because this can affect spermatogenesis. It will cause disruption in sperm transportation. It leads to low sperm count, and it will even lead to abnormal pregnancy, ovulatory dysfunction. In fact, marijuana has been seen to affect the hormones that causes ovulation, production of the eggs, like follicle stimulating hormone and luteinizing hormone. It actually decreases it and leads to ovulatory dysfunction and luteal phase dysfunction. So if someone using marijuana or that cocaine, we advise they stop it, especially for those that are looking for infertility, are looking for that are looking for fertility. Now, heavy drinking also affects cervical mucus, production of egg, causes ovulatory dysfunction in the women, and it causes low sperm count in the men. It also leads to impotence because the man will not be able to perform. So these are effects related to tobacco and causing infertility. Remember, I'm still discussing factors affecting the both couple. Now, we are going to exercise. Exercise can be detrimental, exercise can be of benefit. For someone with polycystic ovarian disease, we advise the woman to lose weight because most times they are obese or they are overweight. So we advise them to lose weight. For men that are obese also, when I discuss men fertility, we also advise them to lose weight. However, you are not expected to lose weight or become so thin. It may affect fertility. In fact, excessive compulsive exercise has been associated with some form of infertility. You know, the athletes, long distance runners, it has been found that it could affect the sperm count. It could lead to oligospermia. So exercise should be moderate, should be moderated. It shouldn't be overdone, so that the woman or the man's fertility will remain for them. Now, the next is inadequate diet associated with weight gain or weight loss. There are some women that cause induced vomiting on themselves. We do not want that. We do not want someone to lose so much weight that the brain will feel it as a threat and will stop menses. So the person will not be able to ovulate. Now, if the person is obese, just like we said, we can encourage dieting so that the person will lose weight. Also, just like I've said before, men that are obese should lose weight because obesity has been associated with low sperm count. However, we do not want you to lose below the normal body mass index, less than 24, it will definitely affect the person's fertility. So with these discussions, all the things I've made, remember I talked about the male factor, the female factor, which comprises of uterine and cervical factor, the tubal factor, ovarian factor, peritoneal factor, and factors affecting both couples. And now, the management depends on what is seen. Whatever that is found out, the management of the couple depends on it. And it's easier when a diagnosis is made, the treatment is far better and more easier. Now, but if we are not able to see anything and we cannot lay our hands that this is the cause of this infertility, we may tag it unexplained. and we say that unexplained contributes about 5% of infertility. So, with this discussion, I think I've dealt very well with factors affecting male fertility and female fertility. We'll go on to continue to discuss other health conditions and how they can be averted. Treatment depends on exactly what is seen. If there's low sperm count, treatment will be started because we'll have to find out what's the cause of that sperm count, low sperm count, and medications or lifestyle modification or surgery will be carried out appropriately where needed. Cervical factor, if intercourse is not adequate, we will encourage them, we will give them or how to do timed intercourse. In fact, whatever that is seen, it is what is managed. And that's why I say the men are evaluated first because the female has barrage of investigation to be done. And with this discussion, I think I've done some works on explaining in a layman's term what causes infertility for both the men and the female or both couples. Follow me for more teaching on the health of the women and the children. Subscribe if you have not subscribed to my YouTube page. Hit the notification button. I am Dr. Nkiruka Bridget at OBGYN Talks with Dr. Ada Zion. Please follow me on Facebook with the name OBGYN Talks with Dr. Ada Zion. I'm also on Instagram, also on TikTok with the same name. Thank you for watching till this end. See you next time.